Immune checkpoint inhibitors, inhibitors of PD-1, PD-L1, and CTLA-4 have now been in clinical trials for glioblastoma for a couple of years at least. They're in various stages of clinical development, phase 1 through phase 3, and also as monotherapy, sometimes in combination, and also in combination with other therapies, including chemotherapy and radiation, and potentially even other immune checkpoints. The early, very preliminary data from the very earliest trials indicated that potentially there were some patients who would benefit, some patients who responded. However, the first large randomized clinical trial of PD-1 inhibition monotherapy was recently reported. It was reported last year in 2017, and ultimately they did not see improved benefit, either survival or progression-free survival, over Avastin monotherapy, and this was with a PD-1 inhibitor. And overall, there were a very small percentage of patients that responded, and although it did seem like those percentage of patients that did respond was durable, it was a very small percentage. And what it really said to us as a field were a couple of things. And again, this was a trial that was done at the recurrent setting. Number one was perhaps the recurrent setting was not the right setting to be testing immunotherapy agents, or at least maybe just monotherapy of an immune checkpoint inhibitor. But the other thing is that there were a few responses, and what we don't understand completely yet is why those patients responded and the vast majority of patients did not. There are certainly intrinsic resistance mechanisms, and again, glioblastomas are amongst the most immune cold cancers that have been studied, so they have very low mutation burden relative to other cancers. They have low expression of PD-1 and PD-L1 relative to some other cancers, particularly ones that respond. And they have very little T-cell infiltrate, and the T-cells that have infiltrated into the tumor are often Tregs, or immune suppressive T-cells, and other myeloid or immune cells that are in the tumor are often suppressive tumors, including microglia or macrophages, the tissue-resident macrophages, the neutrophils, and myeloid-derived suppressor cells. And so encompassing all of those factors in the tumor microenvironment really makes it unlikely that a PD-1 inhibitor, PD-L1 inhibitor, or any immune checkpoint inhibitor monotherapy to be successful against recurrent glioblastoma. What we learned from early experience with immune checkpoint inhibitors is likely that those drugs alone aren't enough, and that we need combinations. So because there are not very many T cells in the tumor, we need a way to drive T cells into the tumor, or increase the number of infiltrated T cells into the tumor. There's various ways to do that. Vaccination is a strategy whereby these tumor T cells can be, and particularly antigen-educated T cells, can be driven into the tumor. And vaccination can be done through various strategies. One sort of in situ way to vaccinate a tumor might simply be just even radiation. So radiation has been studied as a method to incite the immune system within the tumor, increase antigen presentation, increase MHC expression, and also increase the diversity of the T cell receptor within the tumor. This might create a situation where more T cells have now arrived into the tumor, and perhaps increase the efficacy of immune checkpoint inhibitors. So it's one example of a combination strategy that now many investigators are looking into. Many people that are developing novel therapies for glioblastoma, is to combine these immune checkpoint inhibitors with other strategies to drive T cells into the tumor.